Put this chat up. So welcome to everyone. Thank you again for joining me on this Saturday evening. We have a jam-packed session tonight. Please share in the chat where you're from, or if you have questions, feel free to unmute your mic and share if you would like. I would love to know. I'm from Wisconsin, where it is chilly but sunny, and our snow has melted, so that is a glorious thing. Yay. All right. So welcome in, everybody. Welcome to this review. I am Terese. I will be your instructor. I have a co-pilot again today. Welcome for Moniz, and thank you for your help. He is going to man the chat and answer questions for us. I also want to thank my tech support team. Thank you so much for making this all run smoothly. Steve, Carlos, and everybody else that behind the scenes that's involved in making this platform run smoothly. I want to say thank you. You've made this so much easier to manage. This session is key concept review of hemodynamic monitoring and shock management. As you can see, that agenda item list is long. We will begin by discussing various types of hemodynamic monitoring. We will interpret hemodynamic values, critical for assessing patient status. We'll take a look at different types of shock and their management strategies. We'll discuss intravenous fluid administration, central and peripheral venous catheters, complications related to intravenous therapy, administration of blood products, and transfusion reactions. And we will close with a strategy review and, of course, the long-awaited practice questions. So is everybody ready? Let's begin. Types of hemodynamic monitoring. Hemodynamic monitoring provides essential information about a patient's cardiovascular status. We use various methods used to different parameters and reflect heart function and blood circulation. Arterial lines. I'm sure all of you are familiar with them. Art lines are used for continuous blood pressure monitoring and obtaining arterial blood gases or ABGs. They provide real-time data and are crucial in critically ill patients to guide our treatment decisions. Nursing plays an important role to ensure patency, calibrating the line, and assuring that it's zeroed for accuracy. I'm going to say that one more time. Nursing plays a vital role in managing art lines. They ensure patency, calibrate the line, and verify that it's zeroed for accuracy. You'll notice on my screen that some of it is highlighted in red. In this presentation, I highlighted things in red that I think are important or good information to know. They're key notes that you need to understand and remember. You're going to see them again. They will come up. You'll likely see them on your NCLEX, and you'll definitely see them in your practice. Arterial lines are usually placed in the radial or ulnar artery of the wrist and the femoral artery. They require flushing with saline and heparin. How are we doing so far? Am I going too fast? Talking too slow? USA and Texas, sorry I missed you. Welcome. Too fast? Okay, I'll slow it down just a little bit. Okay, central venous pressure. Central venous pressure monitoring assesses the pressure in the thoracic vena cava and the right atrium. It helps evaluate fluid status and cardiac function. Venous oxygenation, saturation, and detailed hemodynamic information on short order. I know that's a lot. It's useful in guiding fluid resuscitation efforts. It monitors the balance between blood returning to the heart, which is venous, and the ability of the right ventricle to pump it out. In hypovolemic patients, the CVP will present as low. In fluid overload patients, the CVP will present as high. So what are the indications for a CVP line? Inadequate or difficult venous access, perhaps you have an agitated patient. Administration of medications that are not compatible with a peripheral IV, therapies like hemodialysis and parenteral nutrition. They also allow for multiple medications to be delivered simultaneously. I'm going to point out on the slide that the things I've highlighted are it monitors the balance between blood returning from the heart and the ability of the right ventricle to pump it out. That's the importance of the venous pressure. A normal pressure is 5 to 12 centimeters of H2O. The other thing I highlighted was that a patient's fluid status, like hypovolemia, will reflect in a low CVP, and a patient's status who has fluid overload will have a high CVP, just to kind of give you some perspective as to what it is you're looking at. CVP can be influenced by higher blood volumes than CVP, lower cardiac output, venous tone, which is due to dehydration, or vasoconstriction. Pulmonary artery catheter. Pulmonary artery catheters are known as Swan-Ganz catheter. They're named after the person who invented them. They allow for direct measurement of pressure in the heart and the lungs. These are balloon-tipped catheters inserted into the pulmonary artery during procedures such as a right heart catheterization. They provide valuable information on cardiac output and help manage complex cases of shock and heart failure, providing overall heart function information. They're essential, especially in cases of heart failure, heart attack, arrhythmias, and pulmonary emboli. They are also used in cardiac procedures to monitor hemodynamic stability, diagnose pulmonary hypertension, and measure core body temperature when hypothermia or fever is critical. You might have guessed these are catheters that you will find in the ICU. Interpreting hemodynamic values. Understanding hemodynamic values is essential for assessing a patient's cardiovascular health. Various parameters provide insight into heart function, flow, and its resistance. This is a big one. Cardiac output. Cardiac output is the volume of blood the heart pumps per minute and is measured in liters. A normal range is 4 to 8 liters. For reference, an athlete can have a cardiac output of 35 liters a minute. That's a lot. That's a pretty strong athlete. It is a crucial indicator of heart performance and overall circulatory function. It influences our strategies for treatment. All right, cardiac output equals heart rate times stroke volume. You can see that on my slide. So now I'm going to dive into that just a little bit deeper, so bear with me. Cardiac output is the volume of blood pumped by the heart per minute, which equals the heart rate, which is the number of times the heart beats per minute, times the stroke volume, which is the amount of blood pumped out of the heart with each beat. Whew, that's a lot, I know. What is important about cardiac output? Abnormal cardiac output can indicate heart failure. It can be caused by heart bypass surgery, congenital abnormalities, or valve procedures. If a physician suspects that cardiac output is compromised, they may order a TEE or a transesophageal echocardiogram to check stroke volume. A heart MRI or a cardiac catheterization are two other tests they may consider doing. What are some symptoms of the patient? Symptoms of a patient with a low cardiac output may present with complaints of shortness of breath, nausea, vomiting, swelling in the arms and legs, feeling very tired, abdominal pain, and a key symptom, this is one to remember, is the inability to exercise like they once were able to. It is the most common symptom of a low cardiac output. Treatment often includes oxygen, inotropic medications, vasodilators, vasopressors, and a mechanical device called a left ventricular assist device, or an LVAD, is what we call it in the hospital. On this slide, you'll note that I highlighted cardiac output is defined as the amount of blood the heart ejects in 1 minute, typically measured in liters. It is crucial for measuring a heart's ability to meet the body's needs. The normal range is 4 to 8 liters. Abnormalities can be an indicator of heart failure. I know that's a lot of information on cardiac output, but if you can remember what cardiac output is for and what it's a potential sign of and what the normal range is, it will be very helpful to you going forward in your practice. The next big one is cardiac index. Cardiac index is a measure of cardiac output adjusted for body surface area. It can be affected by heart rate, contractility, preload, and afterload. It provides a more accurate assessment of heart function by relating the cardiac output from the left ventricle of the heart in 1 minute to the body surface area, and thus relating the performance of the heart to the size of the individual. So it's a lot more of an accurate index. The cardiac index is a measurement to evaluate different forms of shock and circulatory disorders that lead to poor tissue perfusion. Lower cardiac index has been potentially linked to abnormal brain aging, possibly including dementia and Alzheimer's, according to the research being done at the American Heart Association. So it is something to watch. The importance of cardiac index. The normal range is 2.5 to 4 liters per minute by m squared. A score less than 2 can indicate cardiogenic shock. That's probably one of the important things to remember, that a score less than 2 can indicate cardiogenic shock. Systemic vascular resistance. SVR, or systemic vascular resistance, reflects the resistance offered by the systemic blood vessels. It indicates how well blood vessels are regulating blood flow, which is vital in shock management. Why is it important? Because it plays a role in establishing and manipulating blood pressure. Changes in SVR indicate shock, hypotension, vasoconstriction, or vasodilation. For example, sepsis could be represented by a low SVR, or cardiogenic shock could be represented by a high SVR. Think about it like this. SVR influences the workload of the heart. If it's high, the heart works harder. Straining the heart muscle, which can lead to heart conditions like heart failure and hypertension. The higher the number, the harder the heart is working. A normal range is 700 to 1600 dynes, which is also considered as units. Let's see, is there anything else on here I want to make sure you know? It helps evaluate the body's ability to regulate flow. So I guess all of this should be read. That's the important part of systemic vascular resistance. MAP, or mean arterial pressure. Mean arterial pressure is the average pressure in a patient's arteries during one cardiac cycle, systole and diastolically. It is crucial for ensuring adequate blood flow to vital organs. It is the indicator for tissue perfusion. That is a key point here, something you need to file away. It is crucial for ensuring adequate blood flow to vital organs. It is the indicator for tissue perfusion or oxygenation and nutrients to the body. Cardiac output and SVR, or systemic vascular resistance, can affect the mean arterial pressure. Okay, so what's important about mean arterial pressure, or MAP? It indicates organ perfusion, and it is the potential for inadequate perfusion causing organ damage. It can also indicate high blood pressure. It is a valuable measurement in critically ill patients. MAP is another one of those things you're going to see when you're in the ICU, taking care of ICU patients. Does anybody have any critical care experience or work with the critically ill? You can send a message in the chat if you like, or unmute and share that way. I would encourage you to spend 10 or 15 minutes in your organization, if it is all possible, with an ICU nurse taking care of a patient that maybe is on a ventilator, and have them explain the lines to you, what their purpose is, what information they gain from them. You can learn all of these things by reading a book and having your clinicals, but hands-on is probably the most important or the best way. Seeing is believing kind of a theory. It's incredibly helpful to have a little hands-on knowledge of the things that we're talking about here, because they're kind of deep. It's kind of hard to put it all into perspective, but if you can actually see a patient and have somebody run through it very quickly with you, literally in 10 to 15 minutes, it allows you to connect it to the information that you're getting here today. Hopefully that's helpful and made sense to you all. Right. Types of shock. Shock is a life-threatening condition resulting from inadequate blood flow to tissues. Recognizing it, the type, is essential for effective management and treatment. Cardiogenic shock. So we're going to cover a couple of different kinds of shock here, 4 of them actually. And knowing a little bit about shock is really important, and the differences in the 4 types of shock we're going to talk about. So I'm going to try to point those things out. Cardiogenic shock occurs when a heart cannot pump enough blood to meet the body's needs. It can result from severe heart attacks or heart failure. It requires prompt medical attention. It can present with shortness of breath, chest pain, pressure, chest pain, tightness, chest tightness, squeezing that radiates to the arms and the legs and the jaw, a rapid or weak pulse that may be difficult to find or even feel, low blood pressure, anxiety, agitation, confusion, cold, clammy skin, decreased urinary output, nausea, vomiting, and a loss of consciousness or fainting. It can be life-threatening. Treatment is usually IV fluids, oxygen, meds to increase the blood pressure, and heart function support, such as vasopressors, antiplatelet meds like aspirin and Plavix, inotropic agents, and nitro and diuretics, along with lots of other medications, but those are the key ones that are most often used. It needs prompt medical attention. Cardiogenic shock is the condition, I should have made this in red, where the heart fails to pump sufficient blood, leading to inadequate blood supply to the body. So that's the part about cardiogenic shock that is important to remember and will help you identify it differently than the other 3. The next one is hypovolemic shock. This one is a lot more common. Probably people have seen this more so than the other, unless you work in the intensive care unit. Hypovolemic shock is a medical emergency. It is caused by significant fluid loss, like from hemorrhage, related to trauma, GI bleed, childbirth, ruptured aneurysm, or dehydration related to burns and refractory enteritis. Quick fluid resuscitation is critical to restore adequate circulation and prevent multiple organ failure and possible death. Early symptoms and late symptoms occur with hypovolemic shock. These are important to remember also. I did put those on the screen in red. Early symptoms are tachycardia, tachypnea, and a narrowed pulse pressure. Late symptoms are hypotension, oliguria, and cold and clammy skin, confusion, and cyanosis, or that bluish color of the skin. Treatment generally includes, you could probably guess, replacement of fluids, stopping blood loss, and transfusions. Of note, refractory enteritis is the inflammation of the small intestine that does not respond to standard treatment. You may have known that, but I wanted to throw that in there just in case you didn't. How's everybody doing? Everybody doing okay? Go ahead and send a message if I'm going too quick again. The next form of shock is distributive shock. Okay. I don't know which slide is not legible. Let me know which slide it is. I'm going to keep going, but if you want to let me know, I can make the font a little bit bigger for you. Okay? All right. Distributive shock. Distributive shock has three types: anaphylactic shock, neurogenic shock, and septic shock. Anaphylactic shock is pretty obvious. It's an allergic reaction. Neurogenic shock is related to a spinal cord injury. And septic shock, also fairly obvious, is related to sepsis or bacterial infection. So it's a little easier to pick out distributive shock when you're comparing them to the other three types of shock. Distributive shock has three types: septic shock, neurogenic, and anaphylactic. It occurs when blood vessels dilate excessively, leading to inadequate blood flow, causing a drop in blood pressure and reduced flow to the vital organs of the brain, the heart, the kidneys, and the lungs. What are the causes of anaphylactic shock? Well, allergic reaction causes widespread vasodilation. Septic shock, a bacterial infection, same thing, leads to rapid vasodilation. The most common cause of distributive shock is septic shock. That is the one you'll see the most. Neurogenic shock is related to a spinal cord injury. Additional causes, however, can be from burns, pancreatitis, adrenal insufficiency, and drug-related events. It requires immediate treatment and management of fluids and medications to increase survival odds. For example, has anybody seen it, met anybody, or do you have a peanut allergy? This can result in an allergic reaction and be an example of anaphylactic shock. I feel like this one might be a little bit easier because the titles, the anaphylactic shock, neurogenic shock, and septic shock, make it a little bit more obvious as to what type of shock it is. Okay, the next one, if I can change my slide, is obstructive shock. Obstructive shock happens, the title kind of tells you how and why it happens, is when blood flow is impeded due to physical obstruction, such as a pulmonary embolism or a tension pneumothorax, where the lung actually collapses and puts pressure on the heart, aortic dissection, a tear in the main artery, tumor or constriction of a blood vessel, and cardiac tamponade, where the fluid is built up around the heart, creating pressure. Symptoms of obstructive shock are low blood pressure, rapid heart rate, decreased output, cold, clammy skin, confusion, loss of consciousness, and chest pain. It's usually diagnosed on physical exam or with chest x-rays, CAT scans, ultrasounds, or MRIs. Treating the underlying cause is vital to survival. Surgery is usually done to remove a blood clot or decompress the lung. Fluid resuscitation and meds also improve heart function and blood pressure, and possibly mechanical ventilation. So on this slide, you can see what I've highlighted as being important is that obstructive is when blood flow is obstructed by a physical blockage, such as a pulmonary emboli or a clot that's traveled, tension pneumothorax, aortic dissection, tumor constriction, or cardiac tamponade. All of these are examples of what could obstruct. So this one is also probably easier to pick out from the other four or the other three. Common causes include pulmonary emboli and cardiac tamponade. Okay, I'm just going to go ahead and move on to the next one and quickly check to see if there's anything I'm missing in the chat. Make sure we're doing okay. Okay. Management of shock. Shock management focuses on restoring adequate perfusion to vital organs. Treatment includes resuscitation, inotropes, and vasopressors. Fluid resuscitation. Let's talk about that first. Fluid resuscitation is often the first step in managing shock. I'm going to say that again. It's often the first step in managing shock, particularly hypovolemic shock. The goal is to restore circulating volume and improve organ perfusion. Inotropes. Positive inotropes such as digoxin, dobutamine, milrinone, epinephrine, norepinephrine are medications to increase heart contractility or the force of the cardiac contraction. They are particularly useful in cardiogenic shock, heart failure, and myocardial infarction to improve cardiac output and organ perfusion. Negative inotropes, such as beta blockers and calcium channel blockers, decrease the force of the cardiac contraction in chest pain and hypertension. Obviously, we want to slow that contractility down to try to improve the heart's tolerance of the high blood pressure or in chest pain. I'm sure that as you've been practicing in your the hospitals and so forth, you've seen the uses of these medications. Vasopressors administration. Vasopressors make your heart more forceful in contraction. They are critical in managing shock by constricting blood vessels and increasing the blood pressure. They are often used in several cases of distributive shock. These medications are often given IV through a central line or a catheter. They are usually given if IV fluids do not improve the hypotension, because fluid resuscitation is the first line of defense in improving hypovolemic shock. Some examples of vasopressors are vasopressin, phenylephrine, epinephrine, norepinephrine, dopamine, angiotensin II, and terlipressin. Has anyone ever used a nasal decongestant like ephedrine or pseudoephedrine? These are vasopressors. This is just a little comparison of the four types of shock. Cardiogenic shock results from heart failure affecting blood circulation. Hypovolemic shock occurs due to significant fluid loss, impacting perfusion. Distributive shock is characterized by abnormal blood vessel dilation, and obstructive shock is caused by a physical blockage that impedes blood flow. Does that help just a little bit to kind of give you what the differences are? I hope so. There's a lot of similarities, but there are a few differences as well. All right, signs of shock, early versus late. Recognizing these signs of early and late can impact patient outcomes. Early signs of shock. Early signs of shock include increased heart rate, cool and clammy skin, and altered mental status. Recognizing these signs can improve your patient's survival. Heart rate, increased heart rate is often the earliest indicator of shock, signaling the body's response to stress. So that is very important to remember. Cool and clammy skin is a sign of shock as well. You can also have pale and bluish skin, indicating poor blood circulation and the body's reaction to stress. These are still early signs. Altered mental status may indicate shock as well, where the awareness of surroundings will start to diminish as the condition progresses. So in late signs of shock, you'll see altered mental status too, but it is significantly progressed from just altered mental status. You may see rapid breathing, but there'll be shallowed, increased respirations. You'll see low blood pressure, and then it'll suddenly drop very low. You may see nausea, vomiting, lightheadedness, weakness, anxiety, and you may also notice dilated pupils. Late signs of shock. There's your hypotension or low blood pressure. This is when it is a significant drop in hypotension compared to what it was in early. It's a critical late sign of shock and it needs immediate attention if your patient is to survive. Decrease in urine output. Severe confusion. There's your confusion again, but this is severe confusion or lethargy. This is also a late stage shock. The deterioration of health. The severe confusion is the part that signifies late stage in addition to the significantly low blood pressure. Late recognition of shock correlates with worse clinical outcomes and increased mortality rates. One second, please. There it is. Okay, I did say that. I just wanted to make sure I covered all the things in red so that I didn't forget to tell you. So bear with me. Clinical significance of early intervention. Early intervention in shock management can prevent progression to multi-organ failure, which we kind of just discovered or discussed. Intravenous fluid administration is a cornerstone in shock management. Understanding the fluids, the types of fluids, and their appropriate use is essential for appropriate treatment. So let's talk about the types of fluids you're going to use for resuscitation. There's generally three, although they break down into different things, but there's crystalloids, colloids, and blood products. So crystalloids are the medications that have small molecules of salts and sugars in water, like normal saline, lactated ringers, and plasmolite. They're commonly used for hydration and maintenance and electrolyte balance. They're safe, they're readily available, and they're good for general resuscitation and maintenance. The negatives that go with crystalloids are that they can cause edema in excess and they may require large amounts to achieve your desired effect or to improve the hypovolemia. It may take a lot longer. Colloids, on the other hand, contain large molecules that help maintain the blood volume and pressure. They are used in very specific medical conditions as they do not pass through the capillaries. They remain in the intravascular space, drawing into the bloodstream. Examples of colloids are albumin, hydroxyethyl starch, dextran, and gelatin. They can rapidly expand the intravascular volume, helpful in hypovolemic shock. The negatives with the use of colloids is that they're expensive and they don't come without risk. They have an increase in mortality versus using the crystalloids. So in hypovolemic shock, crystalloids are the preference, but colloids would probably be used in a rapid expansion of intravascular volume, or where you need to have a very rapid intravascular volume increase. All right, let's talk blood products. Blood products including red blood cells, white blood cells, platelets, plasma, cryoprecipitates, which are clotting factors. They are used for transfusions to treat medical conditions like anemia, severe blood loss, severe injuries, thrombocytopenia, DIC, hemophilia, and other deficiencies. There are a lot. I tried to pick the ones that I thought were the most common and the most important. Just of note, did you know that O positive blood is the most common in the US and AB negative is the rarest in the US? We obviously must receive compatible blood type in order to prevent a triggered immune response, which is what happens when the wrong type of blood is given, obviously resulting in severe complications. Of note, a person requires a blood transfusion every 2 seconds in the United States. I thought that was an interesting fact. I never would have guessed that. All right, so the things I put in red here are the things that are important about the medications here. So I just wanted to point that out so you can kind of review it. I'm going to go ahead and check the chat and leave this screen up just for a couple of seconds here. So if there's anything. Oh, good illustration. Is this video recorded? Yes, I do believe it is recorded. Yes, it will be recorded, and you can download the slides as well prior to the session ending. You can also get the questions, which we're going to be going through when we get to the end. I'm sorry you missed the beginning. If I had time, I'd go back for you. All right, if I can change my slide, we're going to move on. All right, indications for different IV fluids. Crystalloids for resuscitation are often the first choice for initial resuscitation and dehydration and shock. And you remember that because it's generally, they're the safer choice. But colloids are used when volume expansion is necessary, as in trauma patients, which makes sense. All right, let's talk about administration techniques. Hang on, I got to catch up to where I'm at. Administering IV fluids requires understanding of proper techniques and ensure patient safety and efficacy. Monitoring for reactions and adjusting flow rates are essential. IV fluids and medications can be delivered by IV push, infusion pump, and gravity. This will be determined by your physician orders and the type of patient situation. Central and peripheral venous catheters. Venous catheters are critical for administering medications and fluids. Central catheters are often used for more critical situations or if access is poor and when medications are contraindicated in a peripheral line. Is everybody getting to start IVs at work? Or if you're working in a hospital, is there any experience out there? I'm just curious, are your organizations employing IV teams? Starting to see a lot of that in the hospitals here, where the nurses at the bedside caring for the patients are not necessarily the ones putting the IVs in. In fact, they're doing IV tech education. So you may have a tech come in the room who's part of the IV team, and they're not actually all nurses anymore. They're having the nurses be involved in more of the clinical care and caring for more patients. So I learned that recently. Going to see if anybody answered any of the questions I just asked. I did not get the yesterday slides. Can I see the previous slide, please? Yes. Yes, in the hospital. Yes, good job for those of you who are doing some IVs. And yes, you have a team on board. It's kind of nice to have the IV team on board, I think. Although I personally, when I was working in the hospital, absolutely loved putting IVs in. But it's good experience. And oh, good. Some places don't have IV teams, so the nurses get to do it. I think that's good too. All right. I'm not sure which slide it is somebody wanted to see, but if you download the slides, you'll have them and you can look at them at your leisure. I do believe you can also get these slides after the class. If you go to our website and you hit that little box that says you are here, we're here to help, type the question in there and should be able to help you. Maybe my tech team that's on could answer that question as to how they can get the slides if they can't download them during the presentation. All right, let's move on because we still have a lot to cover. Central and peripheral venous catheters. Central venous catheters. Oh, uh-oh. Did we skip peripheral? Nope, we did. Central venous catheters provide access to large veins, allowing for the administration of medications and monitoring of central venous pressure. They are essential in the critical care department. So again, you're going to see these in the ICU. Peripheral venous catheters. Peripheral venous catheters are most commonly used, and probably the ones you're putting in your patients, in non-critical settings. They are easier to place, but may not be suitable for all medications. We often end up with other lines when we have patients that we can't get access. So let's look at some indications and usage. Understanding the indications for central versus peripheral lines can help healthcare providers select the right access. There is another catheter. The intraosseous catheter is inserted into the bone marrow. It's only used in emergencies when venous access is difficult. And here's just a little comparison. It's very brief, but ART lines provide continuous blood pressure monitoring. Central venous catheters assist in administering medications and fluids. Pulmonary artery catheters measure pressures crucial for cardiac function. And peripheral venous catheters are easier to insert for routine access. That's what we're doing most of the time. It's the most common type. And each line serves a distinct purpose in patient care. What are the complications of intravenous therapy? While IV therapy is essential in patient management, it can lead to complications. Thrombosis and embolism. Thrombosis and embolism can occur due to IV therapy, leading to serious complications. Awareness and preventative strategies are crucial in managing these risks. So, let's see here. Do I talk about a blood clot? Yes. Thrombus is the formation of a blood. I should have highlighted these in red. I apologize for that. Thrombosis is the formation of a clot within a vessel, which we all know. And embolus is a clot on the run. It means the clot took off and traveled through the bloodstream and it's lodging in another vessel. So it can cause potential complications, for example, pulmonary emboli. It obviously can be deadly if you have pulmonary emboli. Some other complications of IVs is infiltration, leakage of the fluid at the IV site, extravasation, which is leakage of a vesicant into the tissue. Sometimes potassium can cause tissue damage if it leaks out into the tissue. Phlebitis, which is an inflammation of the wall vein caused by either the mechanical irritation or the cannula that's left in the IV, infection or chemical irritation, and that would be the medication. Thrombophlebitis is inflammation of the vein with clot formation. Hematoma is swelling from clotted blood under the skin, and that's when you start to see that bruising on the skin. Infection is when we introduce microorganisms under the skin. And allergic reaction. The allergic reaction can come not only from the fluids, but it can also come from the tape or whatever it is we're using to secure the IV in place. Fluid overload and electrolyte imbalance. If you were on Wednesday and saw session 1, some of this might look, you might remember some of it. It might look familiar. Fluid overload and electrolyte imbalances can occur with improper IV fluid administration. Monitoring status and adjusting fluid therapy accordingly is essential. So let's just take a look at the things I highlighted in red here. Improper IV fluid administration can lead to fluid overload, causing complications in patients. You might see dyspnea, swelling, and confusion, and it can certainly exacerbate heart failure. Electrolyte imbalances may arise from fluid overload, impacting various bodily functions and requiring careful management. Some of those symptoms include abnormal labs, muscle cramps, weakness, fatigue, irregular heartbeat. Is some of this sounding familiar to you if you were on Wednesday? Nausea, vomiting, seizure, and coma. What are we going to check for? Hyponatremia, hyperkalemia, and hypocalcemia. Those are some of the important things to remember. Let's talk about blood products. Administering blood products is a critical intervention in managing shock. Understanding the blood types and recognizing transfusion reactions is vital. Types of blood products. Well, we have white blood cells, which contain RBCs, red blood cells, white blood cells, platelets, and plasma. We have cryoprecipitate, which is the clotting factors. We have red blood cells, which are crucial for transporting oxygen through the body and are used in cases of anemia and significant blood loss. We have platelets, which are essential for blood clotting and are used to treat conditions with low platelet counts, such as certain cancers. We have plasma, which is the liquid component of the blood that carries the cells and the proteins, and it is used in treatments for burns, shock, and clotting disorders. We have granulocytes, which are white blood cells, and we have albumin, which is the protein to maintain blood volume. They each have specific indications and are used for different clinical situations. What's the procedure for blood transfusion? The blood transfusion involves careful verification, obtaining consent, and monitoring during and after the transfusion to ensure patient safety. Boy, I just made that sound really easy, didn't I? It's not that simple. It's not hard, but it does have a lot of steps that go along with it. So I'm just going to kind of go through this slide a little bit. I'm not going to read it verbatim. Careful verification of blood typing, where they do cross-matching to make sure of compatibility before starting a transfusion to prevent adverse reactions. Gaining or obtaining informed consent. Make sure you're explaining to your patients when you get consent that they understand the blood transfusion and the possibility of a reaction. Obtain a pre-transfusion set of vital signs. It is imperative so that while you're monitoring vital signs and oxygenation saturations during or post and during, you have some vital signs to compare to. Post-transfusion care, check for any delayed reactions or complications, such as monitoring for fever, chills, rash, or difficulty breathing, along with regular evaluation of vital signs, and that pre-transfusion set of vital signs will give you a place to start. Has anybody been able to hang blood or be part of giving a blood transfusion in the hospital or wherever it is you're working? Yes, yes, we have a couple people who've been able to give blood. Awesome. You can unmute or you can answer this in the chat, but do they require two people to hang your blood for verification of blood type when you're giving it?
Yes.
Okay. That's the usual practice, but I have heard that that is not always the case. So good to know. Thank you for responding. All right, let's move on. Before we start this slide, I wanted to ask a quick question. What if you were the nurse giving a transfusion and a patient develops a reaction? What do you do first? And what do you do following? Go ahead and unmute and answer anybody who is willing.
You stop the infusion and take all the IV stuff out. And you administer normal saline.
Very good, very good. And why do we do that? We do that so the patient doesn't get any more exposure to
And
the
also to the blood that is already in the tube.
Very good, very good. Excellent. Thank you so much for responding. I appreciate it. All right, I'm just going to take a quick peek here before I go on to the next one. Yes, you have to have two. That's correct. We used to have two people to go down and get the blood too, when we'd go get it from the lab. I don't know if they still do that. All right, well, thank you for answering. Good job on that one. That's important. Gonna move on here. If I can figure out how to close the chat. All right. Recognizing and managing transfusion reactions. Transfusion reactions can be mild or severe. Prompt recognition and management is crucial to ensure patient safety. Symptoms can occur immediately or in several hours or days after having a blood transfusion. So I thought that was important to point out. Transfusion reactions can range from mild responses to severe life-threatening complications. They can present as fever, chills, itching, hives, nausea, vomiting. These are all mild reactions. In severe reactions, you might see anaphylaxis, hypotension, respiratory distress. Hemolytic reactions are TRALI, T-R-A-L-I, which is a transfusion-related acute lung injury. DIC, disseminated intravascular coagulation, and sepsis are other reactions that can occur. I don't believe these occur very often. However, I have seen anaphylaxis due to a blood transfusion, and it is pretty scary. Has anybody else seen any kind of reactions to a blood transfusion or even an antibiotic firsthand? Go ahead and unmute if you have and share as we learn from each other. Yes, it's severe. Yes, but mild. Okay. Yeah, they're pretty scary to see. The thing about seeing them, though, once you've seen them, you can remember them and you can connect the dots the next time. So, all right. Let's go ahead and move on. Conclusion of the review. In summary, effective hemodynamic monitoring and shock management are vital in critical care settings. A lot of what we covered occurs in critical care settings. Obviously, not the blood transfusions. We can do them on the floor, not just in the critical care unit. And types of reactions, those things can occur on the floor as well. Types of shock, those are things that you could potentially see as well when you're taking care of your patients. But a lot of like the art lines and so forth, those things are in the critical care department. And I encourage you, I'm going to just say it one more time because I think it's important. It helps you connect the dots and remember, because like seeing is believing, you get to see it hands-on. If you can spend just a little bit of time in the critical care unit with a nurse to have them explain some of the lines just so you can see them, it's a lot easier to remember what it is they're about. So back to the conclusion. In summary, effective hemodynamic monitoring and shock management are vital in critical care settings. Understanding the types of monitoring, interpreting their values, recognizing shock signs, implementing appropriate management strategies are all essential for improving patient outcomes. All right, is everybody ready to look at a few questions? I think we'll do a brief review of some test taking strategies.
Sure.
All right. Does anybody remember any test taking strategies they want to share? You can unmute and go ahead and say them if you'd like.
I would say read the prompt first.
Pardon?
I would say read the prompt of the question first.
Yes, yes, absolutely. That's super important. Actually, that's on my next slide. So understanding the ABCs when you answer your questions airway, breathing, and circulation. No matter what kind of question you're reading, if it affects airway and breathing and circulation, you know which order the correct answers should be. Prioritization is another strategy you can use to answer your questions. Identifying the most important critical needs of the patient ensures that you address the life-threatening situation. Process of elimination is another strategy, and you may end up using all three. Process of elimination can improve test-taking skills by focusing on plausible answers. Systematically eliminating unlikely answers can improve your chances of choosing the correct option. Does anybody use the true and false method when they answer their questions?
Yes.
Yes. The only thing I want to throw out there about true and false, I use it too, and I know a lot of people use it because it is really helpful, is to make sure you read the question and you know what they're asking for. For example, if the question is asking you to choose a statement where the patient exhibits or the patient makes a statement that is reflective that they need additional education or discharge teaching, you may pick the wrong one if you're going to pick the true answer. So just make sure you know exactly what it is that the question is asking. Maslow's hierarchy of needs: physiological first, safety next, psychosocial comes after that. Read questions carefully and pace yourself. Take time to read questions twice if needed. I actually encourage that. If you have time, read the questions twice as best you can. Practice as many NCLEX style questions as you can to familiarize yourself with the types of question you're going to see on your exam. Identify common distractors in each question and don't overthink it. Go with your gut. Do not change your answers unless you are certain you're changing it to the correct one. Common distractors, I just want to mention, a lot of times you'll see opposite answers in the option bank for your choices. A lot of times, like perhaps they say hyperkalemia and hypokalemia. Generally, one of those two is the correct answer. Not always, not 100%. Sometimes those are distractors too. But a lot of times, one of them will be the right answer. You may also see questions that are similar, like high kalemia and hyperkalemia being, the same thing. So those are distractors as well, and you can go ahead and eliminate those. All right, let's begin with some questions. If anybody wants to answer the question after we're done, you certainly can go ahead and do that and unmute. I'm going to go ahead and read the question first. And then I'm going to, if you want to answer, that's fine. Otherwise, then I'm going to give you the answer, and we're going to talk about why it's right and why the others are wrong. Okay? A nurse is caring for a client who is receiving an emergency blood transfusion through a central venous line. Suddenly, the central venous line becomes blocked. What is the priority nursing intervention?
I would say attempt to flush.
Attempt to flush. Okay. Anybody else got any ideas? Let me run through the options. Send a UAP to take the client's blood back to the lab. Notify the healthcare provider. Attempt to flush the line. Make preparations for another central line insertion.
Attempt to flush with some envelope.
So the correct answer is actually B, notify the healthcare provider. Let's review it. So why is B the correct answer? B, notify the healthcare provider. A blocked central venous line is an urgent issue. And if you think about why it might be an urgent issue because you just gave blood, what has potentially happened at the end of that catheter? A blood clot, right? So if we flush the line, we could potentially be flushing a clot.
That's right.
And creating an embolus. A clot on the run is how I like to think of an embolus. Think of it that way. A clot on the run, which we don't want. So a blocked central venous line is an urgent issue, particularly during a blood transfusion. It requires immediate attention from the provider because the provider may have to decide whether or not they want to do an intervention such as a thrombolytic agent to clear the blockage. All right, so we know why C is not correct because we don't want the clot to travel. And we certainly don't want to return the client's blood back to the lab because that's not going to address the problem at hand. And making preparations for another central line insertion would really be up to the physician. It also does not address the problem at hand, which is the fact that we probably have a clot on the end of the line, and that needs to be addressed. So that's why B is correct. Thank you for answering, though. I think it was a good guess. A nurse receives a change of shift report on 4 clients receiving blood transfusions. Boy, that'd be a lot of patients to be taken care of. Which client should the nurse see first? A client complaining of itching, a client with neck vein distension, a client who is vomiting, or a client complaining of a headache? If anybody wants to unmute and answer, feel free.
Yeah, I think number B.
I will go with
Like
B.
an overload. B.
B? Are
B?
y'all kind of picking B?
B
Yes.
is correct. Yep.
I will go with B.
Yes. You're all correct. Client with neck vein distension, B is the correct answer. Why is it the correct answer? Because neck vein distension is a sign of fluid overload.
Overload.
That's right, and may occur if the transfusion is running too high or if the client has compromised heart function. There's a very high risk of respiratory distress. So that is why B is correct. Patient who is vomiting would be an early sign of a transfusion reaction. Itching could also be an early sign of a transfusion reaction, but the fact that respiratory distress could be impending makes the neck vein distension the most correct. And a patient complaining of a headache can occur for various reasons during a transfusion, but it's generally a mild reaction or an elevation of blood pressure. So that's why B is the most right. So very good job. All right. Number 3. A client is receiving a blood transfusion when they begin to experience chills, fever, and back pain. The nurse immediately stops the transfusion. What is the appropriate nursing or immediate nursing action? I know you're all going to get this one right.
Yeah, remove the turbine with the blood. That's right.
Good job. Very good. All right, and we know why that's the most right. Why are we getting rid of the tubing with the blood again?
We don't want to introduce the blood products since it's already causing an anaphylactic reaction.
So what do you think about flushing the IV line?
It's going to push the remaining blood from the tubing and it's going to worsen the situation.
That is exactly right. And what about checking the client's vital signs? Why isn't that the first thing?
Because this client needs an immediate intervention that can be checked after the turbine is removed.
Right? And what about calling the healthcare provider?
They're going to ask you a question. So what did you do?
It's exactly right. I had to laugh because when I first saw that calling the healthcare provider was right, but you have to think through that question. Most of the time, that is not the right answer because you usually need to find out more information before you call the healthcare provider. So anyway, good job. Very good. I'm proud of you guys. You guys are pros at this. All right, number 4. A nurse caring for a client receiving total parenteral nutrition, or TPN, via a central line notices the bag is nearly empty after 6 hours. The pharmacist has not yet delivered a replacement bag. What is the nurse's initial action?
Yes, see.
C, very good, very good. At your hospitals, do they usually have this bag of 10% dextrose outside the room when somebody's getting TPN?
Yes.
Yep. Awesome. Okay, so let's just look at the others to see why they're not correct. Disconnecting the center line and waiting for a new TPN bag. Why wouldn't we do that?
Risk of hypoglycemia.
Yes, that's exactly right. The risk of hypoglycemia. 5% dextrose provides some glucose, but it's insufficient to meet the metabolic needs. And then obtain a blood sugar level immediately and continue monitoring vital signs. Why wouldn't that one be correct? Anybody want to take a stab at it? It's the same thing, hypoglycemia with a discontinuation of TPN rapidly. So good job. You guys got that one too. Number 5, a client who has been initiated on TPN 2 hours ago develops diuresis and low blood pressure. Which of the following is the most likely cause of these signs? High glucose levels, TPN solution infusing too slow, TPN solution infusing too rapidly, infection at the central line used for TPN administration.
C.
That's correct. Very good.
Yeah.
Very good. Did you see that the distractor here, the opposites, I mean, the keys? So we have TPN infusing too slow and TPN infusing too rapidly. Usually one of the opposites is the correct answer. And in this particular case, it is C. So why would A be wrong?
The patient developed diuresis and low blood pressure, not high blood glucose.
Very good. TPN can lead to osmotic diuresis,
Yeah.
causing increased urine output. It also contributes to hypovolemia. And then B, obviously, unlikely to cause immediate changes in blood pressure or diureses, which I think somebody already mentioned. And infection of the central line used for TPN administration can lead to sepsis, which can lead to hypotension. However, it's unlikely to develop in 2 hours post-TPN. So that's why that one is incorrect. All right, good job. All right, here's a good one for you. A client in the intensive care unit has the following hemodynamic values. Check them out in the box here. Cardiac output is 3. Cardiac index is 1.5. SVR is 1800. And MAP, or mean arterial pressure, is 60. Which condition is most likely responsible for these findings? Anybody want to take a stab at this one?
Cardiogenic shock.
Cardiogenic shock. That is the right answer. Good job.
Yeah.
Um,
Because the cardiac output is low.
that's right.
The cardiac output is low and the cardiac index is very low.
Yes, very
The
good.
mean is on the average, which is good, but the output is still low.
Yes. So cardiac output and cardiac index are indicators, if they're low, of cardiogenic shock. That is a key right there. The other thing I just want to point out to you is that cardiac, if you didn't know what the answer was and you had to guess on this question, you'd have a pretty good shock. Because most people know what sepsis is, right? And most people know what anaphylaxis is. So you could eliminate this one and you could eliminate this one. And neurogenic, nerves, the nervous system, you could probably eliminate this one too and probably guess cardiogenic shock. I hope you know the answer, but in case you didn't know, I wanted to sort of point out how just reading sometimes the words can help you eliminate or use the process of elimination and eliminate distractors. All right, great job on that one. Number 7. Did anybody want me to go through why the other answers were incorrect on number 6? If anybody does, just say yes and I'll go back and read them. Actually, there's something kind of important, so I am going to just kind of go back for just a second. Septic shock usually presents with a low SVR due to massive vasodilation from the inflammatory mediators. So something to think about. And while, I'm sorry? While cardiac output may initially be high due to compensatory tachycardia, it eventually decreases as shock progresses. That's all in septic shock. Anaphylactic shock is the severe allergic reaction leading to systemic vasodilation. So I wanted to point that out. Cardiac output is usually increased. And neurogenic shock, characterized by low SVR and bradycardia instead of tachycardia, which is common in other shocks. So I just think those are some key points to know. They'll help you determine which shock is the right one moving forward. Not that you didn't get it right, because you guys did. You did a great job. All right, number 7, a client with a history of severe penicillin allergy is admitted to the emergency department with hypotension, warm flushed skin, respiratory distress after receiving an antibiotic. Which type of shock is the client experiencing?
Distributive.
Yes. And why is it distributive?
Because anaphylactic reaction is experiencing an anaphylactic shock, which is under a distributive shock.
That is correct. Why isn't it obstructive shock?
There is nothing obstructed here. He was receiving a penicillin infusion.
That's exactly right. Obstructive shock kind of gives it away. Cardiogenic shock, we already know, has to do with the heart. And hypovolemic shock also has to do with the dilation. So that is why distributive shock is the right answer, or the right answer. So let me just see if there's anything else in here that I want to make sure I share with you. Hypovolemic shock results in fluid loss, which we know. That also leads to a low cardiac output and a high SVR. Obstructive shock, when the blood flow is physically obstructed. All right, we covered that one, so I think we're good there. Okay, number 8. You guys go ahead and read this one, or read it and answer it. I'm going to read you the question, but a nurse is assessing a client who has a right radial arterial line, or an ART line. Which of the following findings would require follow-up? Anybody want to guess at this one? I'm going to let you think about this one. I'm going to quick peek in the chat, okay? I have a lot of messages that I have not seen. Sarah, you have a question way back when. I hope it got answered. I think Fermoni's was going to try to answer questions in the chat because it's hard for me to read the chat and okay.
D.
Blood transfusion.
D.
Okay. D. 8 is somebody say D. That is correct.
D, yeah, because this 15 millimeter mercury higher than the regular blood pressure. That's right.
Yes, that is
Yeah.
correct. The normal range is like 5 to 10.
5 to 10, yeah.
Yes. So if 5 to 10 would be a normal range, but 15 is much
It's
higher than it
much higher
should
than
be.
the normal.
So that big discrepancy would indicate improper arterial line calibration, or some kind of potential vascular complication of some sort. So that's why D is correct. Flushing is flushing. A flush solution is slowly and continuously dripping in the drip chamber. Why is that one incorrect? Because a continuous slow drip ensures patency of an art line. And B, a transducer is level with the client's right radial artery. It must be leveled with the access arterial insertion site or the fourth intercostal space at the mid-axillary line for accurate pressures. And then A, the pressure bag is inflated to 300. The pressure bag must be inflated to 300 for flushing. So that is why D is correct. So good job on that one. Sorry, I couldn't get my screen to switch. All right, we're almost done. We're on number 9. These next 2 questions are a little harder. They're the select all that apply. These are pretty typical of people who are in the ICU. I just want to throw out there, so don't panic. You're not going to get 100 of these on your NCLEX. I can't imagine that they would do that because there's no ICU clinical rotation that I'm aware of, although maybe they've started doing them, but I'm not aware of it. So just keep in mind when you read these that basics, you don't have to know literally everything on these slides. Just know the basics and you'll be okay. All right. The nurse is caring for a critically ill client with invasive hemodynamic monitoring, including an art line. Central venous pressure, CVP, monitoring, and a pulmonary artery, catheter. Which of the following nursing interventions are appropriate for managing these devices? Select all that apply. A, zero the art line transducer to the phlebostatic access. B, inflate the PA catheter balloon continuously to obtain pulmonary artery wedge pressures. C, maintain the pressure bag at 300 for arterial and PA catheters. D, position the CVP transducer at the level of the left atrium for accurate readings. E, use sterile technique when handling the insertion site of the PA catheter. And F, assess for dampened arterial waveform and troubleshoot by checking for kinks and air bubbles. Whew, that's a lot. Okay, I'm going to let you look at this one for a little bit because it's a lot. And select all that apply, which tells you when you read that question, there's likely more than one answer here that is correct. In the question, it also asks you for intervention, so that's a key word. Make sure what you're picking are interventions. I'll give you a hint. There's 4 of them that are correct.
Oh,
I pick A, C, E, and F. I hope I'm right.
What was that?
A, C, E, and F. I'm not sure, but
A is correct. Zero the art line transducer at the
yes, I did
axis.
philobastic X's, yeah.
And then C, maintain the pressure. We just talked about that
We
one.
just talked about now, yeah.
Good
That
job,
was
guys.
that.
You were listening. And then the next 2 are E and F.
I got it. There you go.
There you go. Use sterile technique when handling the insertion site. Honestly, anytime it says sterile technique and it's a reasonable answer, it's probably a correct answer because we're going to use sterile technique no matter what we do around a line, right? Especially an art line. Assess for dampened arterial waveform and troubleshoot by checking for kinks and air bubbles. Again, that seems like an obvious thing that we would do and kind of troubleshoot for. So A, C, E, and F are the right answers. Good job. Let's talk about why B and D are incorrect. So B, inflate the Pulmonary artery catheter balloon continuously to obtain pulmonary arterial wedge pressure. The PA catheter balloon should only be inflated momentarily to obtain the pulmonary artery wedge pressure, and then deflated immediately to prevent pulmonary artery rupture. That's why we don't do that. The word continuously here is one of those absolute words like always and never. Should kind of give you a clue that that's probably not a correct answer if you didn't know it. And let's see here. D, position the transducer at the level of the left atrium for accurate readings. The transducer should be positioned at the phlebistostatic axis, not the left atrium. The axis aligns with the right atrium, which provides accurate CVP measurements. Okay. So 0 the art line transducer. Let's see if it says anything here about that. That's important that you didn't already share with me. Reference point for leveling the transducer to ensure accuracy. You got that one, so you covered that. Continuous system 300 prevents clot. A pressure of 300 prevents clot formation and maintains catheter patency. That's why 300 is the right answer here. And E, sterile technique. PA catheters pose a high risk of bloodstream infection, so sterile technique would be the obvious reason to prevent infection. And a dampened waveform can indicate a clot or an air bubble or kinks in the tubing, so troubleshooting, checking for connections, flushing the system, and repositioning the catheter. So good job. Very good. That was kind of a tough one, or did you all think it was pretty easy? Going on to number 10 here. Okay, here's another tough one. It's a select all that apply, which tells us there's probably more than one answer. A client is admitted to the intensive care unit with suspected Pseudomonas infection. A client is febrile, hypotensive despite fluid resuscitation, and has warm, flushed skin with a heart rate of 125 beats per minute. Laboratory findings show elevated lactate levels, a white blood cell count of 18,000. Which nursing interventions are appropriate for managing the client? Select all that apply. We have administering normal saline as the first line treatment. We have obtained blood cultures after administering empirical treatment. Titrate norepinephrine to maintain a mean arterial pressure of greater than or equal to 65. Delay fluid resuscitation until vasopressors are initiated. Monitor lactate levels to assess tissue perfusion. Or expect the client to remain hypotensive despite fluid resuscitation. Remembering this patient is hypotensive despite fluid resuscitation. So go ahead and think about that one. Give everybody a couple minutes, and then if somebody wants to go ahead and answer that, I would be appreciative. And Sarah, I want to mention, if you didn't get your question answered, I saw your question there a couple times. We'll get that answered for you, even if we have to send it to you after the class. Anybody want to take a stab at this one? I'll give you a hint. There's 4 of them. So you got a good chance of getting a couple right. Okay, so we're going to administer normal saline as a first line treatment. So it's A. and titrate norepinephrine to maintain a MAP of greater than or equal to 65. And then we are going to monitor lactate levels to assess for tissue perfusion because that's what the lactate tells us. And F, expect the client to remain hypotensive despite fluid resuscitation. Those are the 4 correct answers. And why do we do normal saline as a first-line treatment? Because in septic shock, fluid resuscitation is a crystalloid, and it is the first-line treatment to restore intravascular volume. C, titrating norepinephrine because hypotension persists. If hypotension persists despite fluid resuscitation, vasopressors like norepinephrine should be initiated to maintain the MAP at greater than or equal to 65. And then E, monitor lactate levels because they reflect tissue hypoxia and anaerobic metabolism. Elevated lactate suggests poor perfusion and continued or ongoing shock. And F, septic shock is characterized by persistent vasodilation and capillary leakage. This is why vasopressors are frequently needed in addition to fluids to restore vascular tone and maintain perfusion. So I do want to just touch on why the other 2 are incorrect. Obtaining blood cultures is incorrect because cultures must be obtained before administering treatment.
Yeah.
That was kind of, I hate to say a trick question, or
Yes.
but if you were in a hurry and you were reading them, I could see where you'd overlook that. In fact, I'm going to be honest, I read this the first time I went, oh yeah, definitely, we're going to want blood cultures. And then I went back and went, wait, this says after. Trick. That's a distractor. And then D, delay fluid resuscitation until vasopressors are initiated. Fluid should always be initiated first to septic shock to improve circulating volume. So that is why that one is incorrect. So excellent job. You guys did a great job on those questions. I just want to say you guys can do this. You did a great job on the questions. You graduated from school. You know a lot more than you probably give yourself credit for or realize that you know. Prioritize your well-being by incorporating self-care routines in your study schedule to reduce stress, because stress can be a huge distractor. Time management is very important in creating a structured study plan that allows for breaks and revision. Practice these NCLEX style questions. Attend video webinars. They're very helpful, or at least I hope they're helpful. Seek support. Don't hesitate to reach out support from peers, mentors, or study groups to enhance your learning. NCLEX has a huge question bank, and there are a lot of great questions, so they will help get you ready and prepare you for that, as well as the webinars. Believe in yourself. That's probably the most important thing. Have a positive mindset. You can do this. You will be successful. Don't give up. And I think that pretty much covers my slides. So does anybody want to throw anything out there or share anything?
Yeah, I have a question. So, how can I get the quiz bank you guys have, or do you guys have do one-on-one?
It looks like they're going to start some tutoring. I'm not sure when, but you can look at the website, and it will, if you type in there's a little icon on the right-hand corner, like in this spot here, and it says you are here or we are here. If you type in there, you can ask for what you're looking for, and we'll get it to you. So the questions we just reviewed should be available to you with the rationales. I don't know that I said that during this presentation, but I want to remind you, not only is it important to know the correct answers, but read why the rationales tell you the answers are wrong, because sometimes they can give you insight as into why, oh, this might be right for this question, but it's wrong for this question because of, this, that, or the other thing. It's very helpful as far as having that information. But anyway, you can get that information by typing it in that little, if you can't see it and you can't find it on our website, type it in that little icon that says, we are here. You're looking for questions from session 2, or you're looking for the slides from session 2. Or maybe you asked a question and it didn't get answered. You're looking for the answer to that question, and our content team will help get that answer as well as getting you the questions and the PowerPoints.
No, I mean, my question is, how will I get the question banks that you guys have?
Oh, get
for
into the
preparation?
I can try to answer that. So if you go to the website, the
Okay.
same website via which you how did you access the webinar today?
Yeah, they sent me an email.
Or they sent you an email?
Yes.
But if you go to the website, app.naclex.com, I'm going to send that one in the chat.
Okay.
The question bank is there and you have the first several weeks free. You don't have to pay anything. Just I'm sending the website URL in the chat.
Okay.
So I have sent it. So you go to the website, you will have as many practice questions as you need. And also the tutoring schedule, the syllabus is there under live tutoring. So you can know what are the next sessions when they happen. And so before every lecture, you can see there is a button they have added there says download session slides. And we are going to add a section where we will include slides and recorded videos from previous webinars and tutoring sessions.
All right. Thank you.
She was also asking about one-on-one tutoring, if you can address that also.
Yeah, so if you need one-on-one tutoring, you can email. You go to the website. You can chat with one of our assistants, and then they will you will elaborate what kind of one-on-one tutoring you need, and we'll try to connect you with a tutor.
All right.
And somebody asked in the chat, is the cat and the rat have different questions? Yes, they do. Yes, that every question in the website is distinct. So the cats, rats, different questions.
Oh, thank you so much.
There's also readiness assessment tests on the website that you can access too, in addition to the bank of questions to see where you're at.
Okay.
Yeah, in case you have trouble using the question bank, still there is the chat at the bottom right. Just chat with one of our assistants, they'll be able to help you.
All right. Thank you.
Yeah.
Welcome. Thank you.
I'm sorry, if I'm active member, which one I already pay, should I go back again to the website and find the slideshow?
Yes, I believe starting about Monday or Tuesday, there will be an exclusive section. So if you go to the website now and the live tutoring, let me give me a second here as I try to log back in.
No, because they send me when I'm signing, they send me today and tomorrow it will be another section, but I can see the previous yesterday's slideshow. That's why I'm asking.
Yeah, so yeah, I am aware of that. So right now you access the sessions before you access the slides before the session, but if you check the website on Tuesday, right now under live tutoring, we have the options live tutoring, tutoring schedule, and NCLEX syllabus. There will be another section added there called previous session slides and recorded videos.
Got it. Thank you so much.
It's not available now, but it will be available by end of day Tuesday.
And yeah, and one more question, because when I'm assigning, I have a RAT and CATS question. In the website, it's a separate Q-bank question also, or no?
So the difference between cats and rats, that is the readment assessment test. So for cats, it is about 85 questions, and with every question you answer, the rationale pops up. You answer one question, whether you answered it correctly or wrong, the write-up, the rationale, the explanation of the answers will pop up. So it's a sort of a studying tool, but studying with questions first. The readiness assessment test is like an actual exam. You will have to complete the entire, and remember, one cut is about 85 questions. And but for the readiness assessment test, it's 110 questions. So the readiness assessment test is designed to look like an actual exam. You'll have to do the entire 110 questions for you to reveal the answers, as opposed to the cards where with every question you attempt, the answers are revealed immediately after that question, and then you move on to the next one. The readiness assessment test is when you're finished your studying, when you have done practice using the cards, and now you want to see how you could fare in an actual exam. So you attempt the readiness assessment test as you could an
No,
actual
that one
exam.
I understand because I used to do.
Okay. What was your
No,
question?
I understand that. I'm keep doing both of them, same time. RAT and SAT. I'm doing the both the same time. I pay for that for 3 months and I'm doing it. When you say sign up for the website for the QBank, they have different question also. That's my question.
The QBank?
Yes.
So do you want to know if we have more questions other than the cards and the readiness assessment tests?
No, because you said when for the other people, yes, beside that rat and cat scan, you have a separate test, and I say you have over there the case study also, yeah?
Mm-hmm.
Yes. So beside all of that, when you say you go to the website and they have a free QBank question, that's another question, or that's all which one we already have in cats and the rats?
It's what's already in the cards and the rats.
Okay, got it. That's it. That's my question.
Yeah.
Thank you so much. Thank
Yeah.
you. I already have that. Thank you.
All right. Did anybody want
Appreciate
to
it.
ask
Thank you.
anything about the service?
Nimrod, can you address the questions and where they can access them? Are they going to be in the same place that the slides are?
The questions you have used today?
Yes, the 10 questions that we review in the webinars with the rationales, are they going to be able to access them after the webinar?
They're already built in the slides, aren't they? No?
Yeah, please,
But
can
the-
the
but the
slide be
rationales
can
are
they
not.
send the slide to us via our email or something? Because I'm finding it very difficult to access it.
All right. Okay. Yeah, that has been okay. I will ask that the slides be sent to all the people who attended today. But
Okay.
like I said, on Tuesday, end of day Tuesday, there will be an exclusive section on the website that has all the slides and recorded webinars from previous sessions. But at least for those who attended today, I'm going to ask them to send the slides.
Okay.
Okay,
They
please,
won't
can we have
And one more
a
question. The
NCLEX
last year,
group or something like a WhatsApp NCLEX group or something?
when
Oh, did you want a chat room?
Yes, a chat room, yes, where we can, sometimes you're just alone and probably some other people you want to chat with, they are not using the same question bank with you. So since we have the same like mind here, can we just organize like a chat room where, and it will be very helpful. So we'll just be on the same page.
And do you want to do this on WhatsApp?
we can,
We can organize a chat room. Which is the preferable platform to do it?
Yes, WhatsApp, please.
All right. I will look into that, and I will look into that, and I will.
So how do we, with WhatsApp you need our numbers or what?
we can
Yeah.
chat. Can
Or
we
just
chat
send
now?
the link, or just send the link. We'll just come in so that we have the NASLEM group together, not like other group that different people are using different question bank and all of that. And people kind of talk down on some question bank. Of course, we that have been using NASLEM, we can see the the benefits and all of that. So we'll have the same like mind, we'll be able to relate better. So I think you should just probably do a WhatsApp group for us. So just send a link there, we'll just create it, and it will be helpful for us.
All
And
right.
once in a while, people can come in and just help us.
That's fine. So I will look into that, and if it could have been created in the next session, I'll have the links for you.
Thank you so much.
Link for you. Yeah.
Because in Tuesday lecture, the presentation, I don't know how, but the instructor show us we can download as a PDF file and we can have it right away. So nobody involved it for the OBGYN question, maternity day.
Are you saying you need Tuesday slides and you don't have
No,
access?
I already have it. The Tuesday, which one is a March the first presentation, which one already passed. That's the Tuesday evening. We have a class in March 18. So the instructor show us how to download, and right away during when the lecture is finished, we download and we have that's as a PDF file.
All right, all right.
You send us some link, and we right away we download it and we have that slide in our computer. Please, if it's possible for future, if not, just send us link and we can follow the how to do.
So you did you want the slide to be dropped in the chat?
Yes, please, because as she was saying that it's on Tuesday, we had link, so we could download the
Right away
PowerPoints,
when the
yeah.
yes.
So if it can be possible to do something like that, we'll greatly appreciate.
So Terese, can you if you have the slides saved on OneDrive, could you drop the link
Sure,
in the chat?
I can give it a shot.
All right.
And if
Thank
it's possible, if it's work,
you.
can you do the also yesterday lecture?
For yesterday's lectures, you want the slides too?
Yes,
please.
because yeah, they says that they're going to put it, but never happened. I
If
think
it's
they
because
forgot
it will be easy for you and for us right away when they drop it and we can download and finish up.
All right. Okay. So the tutor will drop today's the tutor will drop today's slides. Regarding yesterday's slides and the ones before that, we'll probably have to post them on the website. But also I'll ask the tutors to be dropping the link in the chat anyway.
Makes
As we-
sense.
as we
Yes,
work
thank you. Thank you so much.
Thank you so much. We really
Thank
appreciate your
you
help.
very much.
Thank you.
Yeah, thank you very much.
There you go.
Thank you. Thank you so much for your time.
Thank you.
and
Really
help.
appreciate your help.
Thank you. Thank you, both of you. Thank you so much.
You're very welcome. You guys did a great job.
Okay,
Thank you
yeah,
for
I just
joining
have
me
one
on
more
your
question before we
Saturday.
go. Like, what should be like a percentage when you'll be sure that, oh, you're good to write the exam? Like, what's the percentage should be like? What should be the percentage?
You mean when you're taking the
Yeah, your cat and rats, and so
when you're
what, like, at what level should you get to, and it gives you like the kind of confidence, and you say, oh, you want to go and write the exam. All right, I'm saying 65 and up. Okay. Don't say 65 and up. Okay.
I would say push it up to 75, Mama. I've been in that shoe. 65 getting good help.
Yeah, I would have to agree that above 60.
I mean, when you're doing your CAT, like 65, good. But when you get to readiness assessment, because when I chatted with one
Yeah.
of the representatives, the readiness assessment, mainly, I think those 8 exams or 9 exams are the one, like, you're going to know that, okay, I'm ready for NCLEX. That was what I was told. If you can get anything above 70. So I just try to push myself a little bit further.
So is the 70, what's the is there a recommended number, Nimrod, on what they should achieve
Yeah, they said 65 and above.
for both the cat and the rat?
For RAF, yeah, on CAF, yeah.
Okay.
Just a second, Terese. So please copy the link. You have the link there, but
For
I
the
don't.
WhatsApp group. Okay.
Yeah.
It's there.
Could you copy it and drop it in the chat? I don't
I
think
did.
Do
it's
so.
in
You
the
want
chat.
it again?
Yeah, it didn't come up.
Yeah.
It didn't come up. I didn't say it.
Yeah. Could you drop it in the chat, please?
Just copy and paste.
Saying it.
Did it work?
Nope.
It's
No, it didn't come up yet.
it is showing on your screen. We can see
Or
that.
should we just drop our number or something?
And then just could you paste? Could you, after you've copied it, go to the Zoom chat and send it as a
Paste it. Yeah.
And send it where? I'm sorry.
You just you copy that link and then paste that on the chat.
That's
On the bottom there is the participants, and then there's chat. there is participants chat, and click on it and Control V.
Hang on.
Or should we
Where
quickly
we
drop our
chat?
numbers?
On that side where we chat, just on the bottom there, you can
Yes,
just paste it.
right here.
I don't see it, but
A little bit down at the chat. Don't.
This literally right here.
no, on the Zoom. On the Zoom.
On the Zoom. You have
Yeah,
to go back
not
to
on the
Zoom.
slide, on the Zoom.
I'm sorry, I don't know where you're talking about.
Can we quickly drop our numbers or something?
It's going to be a lot because we are 43 of us
Dropping
here.
numbers will be a lot.
Okay.
Yeah, like to put that
Could
link
you
is going to be
could you
easier.
go up?
Yeah, well, you can send the link to us and through our mails or something when you're done, if you're struggling with it.
Yeah, it's,
How about that?
we had a problem with copying it before too.
Okay, but don't. Okay, that's fine. We will have them sent via email to everybody.
Please just send it to our email, so we'll just pick it up from there.
All right.
Yeah, thank you.
Maybe if you want, I'll help you out. If you share your screen with me, so I can copy it and paste it.
Nimrod, I'm not really sure how.
Oh,
To
no.
share?
How else to share?
Okay, on the bottom there on the Zoom.
Click a share.
There's share. There is a
This is a share
arrow
button.
up, right?
The red
Yes.
one.
Arrow.
Green.
It says share.
Uh-huh.
So click that one.
That's what I did.
Okay, so I don't see it.
I think you have to double click the share.
You're not clicking the right one, Em.
Oh.
You have to go to the
Nimrod,
Zoom.
you'll just have to, can you please
Just
take
take
care
your
of
time, create it and send it to us via email. We'll get
Yeah.
it there.
Yeah, let's
Yeah.
do it that way. It's
It will
confusing.
be sent via email.
Please,
Thank
yes, please also
Yeah.
yesterday presentation, yesterday and today, both emails.
Yeah,
please.
we'll get it on the WhatsApp
Maybe
group
you
where
should
we'll start,
minimize
yeah.
your screen, then you go to your Zoom page. Maybe you'll be able to see your Zoom page if you minimize your screen.
Yeah. No. Okay. Nope.
I tried to do mine to share
Yeah.
with you. Can you see me?
I can see you.
Yeah. So just, click under my name.
Yes.
Okay, after you click on my name and then go to share and then I can see it.
Are you there?
Yeah, I can see it. Yes. Okay.
So PowerPoint?
Yeah, but it's still, you are the one who have control. I
Right.
wanted to copy do you see my arrow? No, you don't see my mouse, yeah?
No, I don't see anything.
Yeah, because you didn't share it yet.
Share.
I think they should just create it and just send it to us via email. That's
Thank
okay.
you.
Yeah, maybe via email then.
That's
But
it.
we
Yeah, guys, thank you so much for your presentation.
You're very
Yeah.
welcome. I hope
Thank you
really
so
appreciate
much.
all this help. This is perfect live tutoring. Thank you so much.
you're
Yeah,
very
you
welcome.
make me easier to understand all the
Yes,
material.
that's very easy. Most easier.
Yeah.
Thank
I had a problem with that topic.
you. See you
Thank
soon.
you. Thank you so much.
I know, me too. Thank you.
Thank you.
And we have a wonderful
you.
evening.
Thank
you so
you
much.
guys as
Enjoy
well.
your weekend. Thank you.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Good
Bye.
luck, everybody.
Thank
Good
you. We
night.
need it.
Thank you.
You'll be
Thank
okay. Have faith.
Okay, thank you. Thank you so much.
You're welcome. Bye.
Okay, bye-bye. Bye-bye.
Bye bye. See you. Thank you.
Thank you.